All right, well, thank you to everybody who is on the line. Welcome to the Washington State Healthcare Authority's Telehealth webinar for Apple Health or Washington Medicaid. My name is Matt Ackerman. I am the Clinical Quality and Care Transformation Communications Manager, and I will be kicking us off with some housekeeping items before I turn it over. Next slide, please. So, as I mentioned, we will do the housekeeping, then an introduction to the Healthcare Authority. We'll be overviewing telehealth, along with additional telehealth policies, best practices, and resources, and then a question and answer session. Just a quick word about our question and answer session. We have an action-packed agenda, so I encourage you to use the question function to submit your questions, but also keep in mind that this webinar was built with questions that we've already received in mind. So go ahead and put your questions in if you have them. They may be addressed in the webinar, and then please do not use the hand up and down function. Next slide, please. So it's a great idea to close other windows that you're not using, frees up the bandwidth. And if you are participating via phone, go ahead and mute your computer speakers and microphone and enter your audio pin. Next slide. So this webinar is being recorded and will be posted to the Healthcare Authority's COVID-19 page, and it is open to public disclosure. So please do not disclose any private or confidential information. After the webinar has concluded, we will be sending out a short survey, and it's an opportunity for you to provide more input on this webinar and additional webinars and topics. Next slide. So a quick introduction to GoToMeeting for those of you who have not used it. We have the Grab tab at the top. It allows you to open and close the control panel and control your audio controls. We have an audio pane which will display your audio format. Click settings to switch between phone or computer should you need to switch. The hand icon is what I mentioned earlier. We're not going to be monitoring the hand icon because of the number of attendees we have here, so please do not use it. Use the questions pane below to send your questions to us. And then we have the attendee list, which displays all the participants in session. And now let's see, next slide, please. So I'll turn this over to the Healthcare Authority's Associate Medical Director, Dr. Chris Chen.
Thanks so much, Matt, and thanks everyone for participating in the webinar today. My name is Christopher Chen. I am an Associate Medical Director for Medicaid here at the Healthcare Authority, and wanted to start off with a quick thank you for everything that you guys are all doing in the community, taking care of the residents of Washington State, and hope everyone is staying home and staying healthy. As Matt mentioned on the webinar today, I'll provide a quick introduction to the Healthcare Authority for those who may not be familiar with the work that we do, and then kind of move on into an overview of our telehealth and telemedicine program, as well as a review of specific policies, and then ending on best practices and resources. So the Healthcare Authority is Washington State's largest healthcare purchaser. We purchase healthcare for more than 2 million Washington residents through a few different programs: Apple Health, also known as Medicaid, the Public Health Employees Benefits Board program, the School Employees Benefits Board program. And specifically for Medicaid, we work with 5 managed care organizations, and about 85% of our population is enrolled in managed care, with the remainder of Washingtonians enrolled in our fee-for-service program that's directly administered by the Healthcare Authority. You may also know the Healthcare Authority via Provider One. The agency has been super busy in response to COVID-19, as I suspect many of you all have. We've been partnering with our across agencies at the state, including the Department of Health, where Incident Command lives, in leading the response to COVID-19, working with local public health, Department of Social and Human Services, Department of Corrections, and the Department of Children, Youth, and Families. We've had a number of initiatives supporting providers, including providing additional funding and resources to support the healthcare system, such as hospitals and behavioral health providers, as well as seeking additional flexibility by enacting emergency rules and obtaining emergency waivers. In addition, we've been working hard to protect our community members, ensuring coverage and eligibility, especially through our Alien Emergency Medical Program, and initiatives like continuing coverage by waiving termination of coverage, and also supporting COVID-19 testing and drive-through testing. Just a quick word on COVID-19 testing. We may have a guest appear later in the webinar, Dr. Charisse Fatinos, who is our Deputy Chief Medical Officer and has been working across agencies leading our state testing strategy. So we may end up flipping back to this slide if she's able to dial in. Also, specifically regarding billing on COVID-19 testing, if you're wondering, we do cover the PCR tests, U0001 and 0002, as well as the high throughput technology codes 3 and 4, and those should be billed with modifier CR. Drive-through testing is also covered through a specimen collection code 99001, and those details are available, as is most of the content of this presentation on our website. You'll see at the bottom here, sourced our COVID-19 FAQ. Also, and Dr. Fotinas may mention this later on, there is a testing survey that is being collected to try and understand the various considerations in testing for providers who order the tests. So moving on into an overview of telehealth. We recognize that in the healthcare community, the words telehealth and telemedicine are often used interchangeably. These words and their definitions can vary based on where you are in the ecosystem. For Washington Medicaid, very specifically, we observe state and federal rules, and so have very specific definitions of these two terms. For telemedicine, by state law, it is defined as the delivery of healthcare services through the use of HIPAA-compliant interactive audio and video technology, permitting real-time communication between the patient at the originating site and the provider for the purpose of diagnosis, consultation, or treatment. Telehealth is considered an umbrella term that includes telemedicine as well as other temporary policies, including technologies that may not be HIPAA compliant and may not be conducted through interactive audio-video exchange, including other forms of telehealth such as online digital exchange through patient portal, telephone calls, FaceTime, Skype, which are our non-compliant, non-HIPAA compliant audio-visual technologies, and email. As a quick background, we all understand that we're experiencing some pretty significant changes in society, and the healthcare delivery system is undergoing a rapid shift as well. And Washington Medicaid is very committed to access and continuity of care during this time. For services that are appropriate to be delivered via telehealth, telehealth can be a very critical modality for patients and providers. Even prior to the pandemic, Washington Medicaid did pay parity for services that were rendered via telemedicine, and those services were paid at rates the same as those that were provided in person. And additionally, in response to the pandemic, we've made additional policies available for providers to continue providing high quality care to patients. And we've noted where services apply for the duration of the pandemic only. We will be sure to communicate any changes to these policies with ample notice, supporting a return to office-based care. We're all very invested in a very smooth transition. And we'll be working with providers on an ongoing basis to identify modalities that may be continued in the post-pandemic telehealth program. This slide is covering telemedicine billing procedures. Again, this was a policy that existed even prior to the pandemic. This is a pre-existing Washington Medicaid policy for services that are provided via HIPAA-compliant real-time audio-video technology. So that's a live audio-video feed. And these services are paid at parity. And should be billed using the usual CPT HCPCS codes, if applicable. Additionally, with place of service 02 for the distant site, originating site facility fee may be eligible if the certain criteria are met, which I'll discuss on the next slide. And if you are a non-facility provider, need to add modifier 95 to receive the non-facility reimbursement. For the originating site facility fees for telemedicine, for qualified sites that use HIPAA compliant real-time audio video, the originating site is the location of the client at the time they're receiving the service. And an originating site facility fee cannot be billed when a client is at home and the provider and client are in the same location. So covering telehealth, again, telehealth is defined as our services provided via other modalities, including non-HIPAA compliant real-time audio video, such as FaceTime or Skype, audio-only email patient portal. And this is allowed temporarily for the duration of the pandemic using the usual CPT HCPCS codes that are applicable and paid at parity. For telehealth billing, the place of service indicator that should be used is the one that best describes where the client is. 12 for home, 31 for a SNF, 13 for assisted living facility, etc. And please do not bill with the provider's location as the place of service. These services are not originating site facility fee eligible and should be billed with the CR modifier. So as mentioned before, in addition to our telemedicine and telehealth policies, we've made additional policies available for the pandemic and would like to review them with you here today, including real-time audio only, interprofessional communication / e-consults, online digital services, virtual check-ins, primary care exception, after-hour services, well child visits, office-based opioid therapy, PT, OT, and speech therapies, and dental services as well. Please note, specific billing instructions may differ by MCO, and the following slides reflect policies current as of April 30th. We'll be keeping our FAQs updated. The FAQs are located on the Healthcare Authority website. And for behavioral health, we have developed separate guidance and webinars that are also available on the website. And I'm just going to take a pause here. Dr. Fatinos, do we have you on the line?
Yes, I'm on the line, Chris.
Great. I can go back to the previous slide a little bit. If you'd like to talk a little bit about testing.
Sure. Great. So wanted to just update this is Sharisa Fatinos, from the Medicaid. I don't even know who I work for anymore, but anyway, wanted to update you all about the state testing strategy. Recent updated guidance was put out on the Department of Health website yesterday about expanding the criteria for testing. And I know that the flip side of that is, yes, we would love to test more people, but we have limitations of both supplies on the specimen collection side as well as the lab processing side. Some of those supply chains are improving, so hopefully we'll be better able to provide adequate supplies for people to be tested. Essentially, the guidance has expanded to include anyone with symptoms consistent with COVID, and symptoms consistent with COVID are by the CDC's new definition, which includes myalgias, shaking, chills, loss of taste or smell, fever, shortness of breath, cough, and sore throat, and headache, actually. So they've broadened their inclusion of symptoms just a couple days ago. So the new guidance says anybody with those symptoms, mild, moderate, or severe, can have testing. There are some recommendations around studies in which asymptomatic testing would be desirable. That's when a person is in close contact with someone who has tested positive, or in congregate living or work facilities. We're seeing outbreaks now in farm worker housing, meatpacking plants. So really giving the local health jurisdictions the opportunity to test more broadly to people who might be at risk and exposed. So that testing guidance went out yesterday. The strategy really for the state testing plan is to make available as quickly as possible after someone with symptoms has been identified a test. That test specimen can be collected, sent to a lab with the goal of that lab turning it around in 24 to 48 hours. We're working with all of the different labs in the state, recognizing that Quest and LabCorp are processing labs for the entire country. Looking just at our Washington state labs, we have a capacity now to do about 20,000 tests a day. So working with them to make sure that they're able to accept specimens and that those can be sent, at least from the local health jurisdictions who are out doing the outbreak testing, into all the labs across the state for improved efficiency. We are working with private partners to see if they can help support some testing locations, whether that be a pop-up or a drive-through location. There should be more information about those, trying to really make available across the state locations for people who might not have internet access or smartphones or other ways in which to request testing to be able to go to locations. So hopefully we'll have some more information about where those are available coming up. One of our big focuses in the testing strategy is on equity. We recognize that not all populations have access to either testing or information about testing. So we'll be working with different community leaders across different groups, starting with King and Pierce, to help understand what community needs are and what the best way to help support them in supporting their communities to get tested and feel comfortable and safe doing that, given traditional concerns that different populations may have. I think that I want to say a word about testing in general. Right now, there is not just inequity in testing certain groups, but in who has access across the state. The testing that the Department of Health is really trying to get supplies for and provide to are for those outbreak testing for folks who are uninsured, testing for healthcare workers or first responders who don't have access through their own health insurance or other ways to get tested. So sort of that group of folks that aren't, traditionally being seen in the healthcare system. As it were, the healthcare system still provides the bulk of the testing across the state, whether that's hospitals, health systems, or clinics. So the public health acquisition of supplies and distribution is to supplement that for groups that might not, readily seek out care in current health systems. The two types of tests, as you're all well aware, are the molecular test, the PCR test, checking for the virus, and the serology test, the antibody tests. Really, the testing guidance right now focuses only on the viral testing. We know that there are some hospitals and health systems that have the resources and are testing everybody, all their inpatients, everybody before a procedure. That is not necessarily consistent with the guidance because, again, we have people in other parts of the state who are symptomatic who we can't quite get tests to. So hopefully as the supplies improve, there will be less of that disparity, but there does exist some now. Serology testing, as I said, antibody testing, really its only utility from the perspective of public health, and I think the clinical perspective is it's interesting for public health surveillance. It's not an informative test, as you know. We don't know if someone has antibodies, what kind of protection, if it confers immunity, for how long. So we just don't have enough to make any reliable conclusions based on antibody testing. I know that there is a lot of federal press, a lot of sort of public hope that antibody testing will be what people need to return to work, but as you know, we just don't know enough to be able to say, yes, you're okay to go back. You've been exposed to COVID and you're safe. That's a false reassurance we can't make right now. Also, some of the caveats of the viral testing, people can be infectious 5 days before they develop symptoms, and their viral loads may not be high enough at that point to pick up. So have to be thoughtful about when we're testing people who are asymptomatic, being careful to ask about contacts and recognizing that that test is good for about 5 days, but they could still be infectious and have symptoms. So a lot of thinking that needs to happen to come around what kind of testing strategy we have for folks who are asymptomatic, and in what setting does that make sense. The current focus right now, therefore, is on symptomatic folks with that broadened definition, and really, because we don't have the capacity to test everybody at some interval, whether that's 7 days or 14 days, to see if they started shedding virus, that's not a sustainable solution right now, or the solution that will get everything open again. Really, the focus has to be on getting systems in place to identify and help people identify symptoms that might be consistent with COVID early, have them reach out to healthcare providers to ask about testing, get testing for them, rapid turnaround. If they're positive, public health, will reach in to isolate and then do contact tracing. So really catching positive cases as soon as possible, containing them is really going to be the way in which we reduce community spread and kind of, lessen the overall prevalence as we go forward. So I think I'm going to stop there. The billing, you can see the PCR tests are covered with the codes on the screen that you can see. And if there is drive-through testing, the specimen collection code 99001 can be used. We've also sent out a survey, and I apologize to some of you, you're probably going to get it from multiple directions. But really, the better we can make the case for the gaps in what you need to do testing right now, whether that's PPE, supplies, access to a lab, the more we can ask for resources. So again, you'll be getting a survey on behalf of Kathy Lofi about barriers to testing. I apologize that it might come from several directions, but if you have a couple minutes to take it, that would be greatly appreciated. And I will stop there.
Great. Thanks so much, Dr. Futinos. Really appreciate the update there. And we have the survey link here posted for everyone. The webinar materials will be posted on our website after the conclusion of the webinar as well. So you'll be able to access this link later on. Great. So just going to jump back in quickly into the review of the additional telehealth policies that we've made available for the pandemic. Just want to remind everyone that these are available on our website. The link is here. You'll see information about coronavirus, and under this section entitled Providers, Billers, and Partners is where you can see all of the FAQs that informed today's presentation. So the first section that we have here is on real-time audio only phone visits. We have opened 3 telephone codes with the intervals that you see below, 99441, 2, and 3, that are allowed for the duration of the pandemic. These can be used for new or established patients. And we've had some questions about who is initiating the call, and these can be reimbursed for providers initiating the phone call. These are encounter eligible and are mapped to rates that are comparable to in-person visits as well, the outpatient D&M visits. And so these can be billed with a CR modifier. For interprofessional communication, 99446, interprofessional telephone and internet consultation, was a pre-existing Medicaid policy code that was available, for which over half the time must be spent in verbal and electronic feedback. So a verbal and a written report to the requester is needed. And additionally, 99451, interprofessional telephone, internet, electronic health record, assessment and management service by a consultative physician. This is also known as e-consult and is allowed for the duration of the pandemic as well. This involves a written report to the requester, often primary care provider who is requesting assistance from a specialist. These can be billed with a CR modifier. Online digital services, this group of codes 99421 to 423 refers to e-visits that are conducted via patient portals, often linked to electronic health records. These codes have 3 time intervals for 421, 422, and 423. This is allowed for the duration of the pandemic for new or established patients, also encounter eligible, and rates are comparable to in-person visits. Virtual check-ins, G2012 is available. This is for a brief check-in with provider via telephone or other telecommunication device, including text messaging. This is allowed for the duration of the pandemic for established patients only, is encounter eligible, and built with the CR modifier. A quick note on the primary care exception. For the pandemic, Apple Health Medicaid, we are aligning with the Medicare policy to allow all levels of an office outpatient E&M service provided in a primary care center to be provided under direct supervision of the teaching physician in person or by interactive telecommunications technology. Please remember the appropriate level of supervision should be in place for all residents based on each resident's level of education, training, and ability, as well as patient complexity and acuity. In additional support of primary care employing telemedicine or telehealth, we also have after hours and weekend care service codes available. 99050 is for other than regularly scheduled hours, and 99051 is during regularly scheduled evening weekend hours. Again, these are for services that are provided by primary care and behavioral health providers via telemedicine or telehealth, and are add-on codes that should be billed with a CR modifier. For those who are providing well child visits, we recognize that some components of a well child EPSDT visit may not be able to be completed remotely. And as these components are critical to the well-being of children and youth, there will be a need for a follow-up appointment to complete these components. For that, for the EPSDT appointments that are conducted via telemedicine and telehealth, please use the usual visit procedure codes as appropriate and bill with modifier CR. In conducting an in-person follow-up appointment to complete those components, you can use 99429, the unlisted preventive medicine service code billed with the modifier CR. Also please note that for that EPSDT appointment conducted via telemedicine telehealth, that is a CR modifier for both the telemedicine HIPAA compliant real-time audio video technology, as well as if conducted via telehealth. For office-based opioid therapy, there's an additional code 99211, a nurse phone call to provide contact and support to assist in accomplishing treatment goals. This is available for the duration of the pandemic and is a separate E&M billed by the provider to be used in lieu of a face-to-face E&M billed with modifier CR. And please note this excludes services funded through a contract with the healthcare authority, such as OTNs, hub and spokes, nurse care manager projects, etc. For PT, OT, and speech, there are additional phone codes allowed for the duration of the pandemic, 98966 to 98968. Telephone E&M codes by a non-physician healthcare provider at 3 time intervals, allowed for new or established patients with a modifier CR. And then for dental, there are 3 additional codes, D0170, a reevaluation for limited problem-focused visits and post-op visits. This is temporarily allowed for all dental providers and may be billed with teledentistry and can be used 3 times in a 12-month period at a rate of $10. Another code D9992, which is a temporary code for phone triage and care coordination if unable to complete teledentistry. This should not be billed with teledentistry codes, and the rate is $15 per client per day. For FQs and RHCs, this code does qualify for the encounter rate, and if a phone service results in an in-person visit on the same day by the same dentist, HCA will pay only one encounter rate payment. And this third code, D9999, family oral health education, may be billed with teledentistry if criteria in the ABCD billing guide is met. All of the policies that we reviewed are available at this top website. Additionally, the Medicaid managed care organizations also have specific billing instructions at the links below. And a word on documentation. So documentation requirements for telehealth services are the same as those for documenting in-person care, and at a minimum should also include the date of service, including start and stop time or duration of service, the names of all participants in the encounter, including other patients and providers involved, and the location of the client, and the location of the provider. And in noting the location of the client, any medical personnel that may be with them, if they are not at home, then that should be noted as well. Please document that the encounter was conducted via telehealth, which telehealth platform was used, and whether it was HIPAA compliant. If a physical exam is conducted, please document whether vital signs and exam findings are self-reported by the patient or obtained under direction of the provider providing the service. And for guidance regarding consent, please see our FAQ online. Moving on into best practices and resources in providing telehealth. And please note the following are recommendations, not necessarily policies or rules. When conducting telehealth services, it's important to ensure that the standard of care for telehealth is the same as that for an in-person visit, providing the same healthcare service. And best practices include the below, but not necessarily limited to. Please consider the patient's resources when you decide which platform to use. Test the process and have a backup plan. Connections can be disrupted with heavy volume, and communicate that backup plan to your patient in event the technology fails. When starting the visit, introduce yourself, what your credential is, and what specialty you practice. Show your badge if applicable. Ask the patient their name and verify their identity. Consider requesting a photo ID of the patient if available. Inform the patients of your location and obtain the location of the patient. Include this information in your documentation. Inform the patient of how the patient can see a clinician in person in the event of an emergency, and also inform patients that they may want to be in a room or space where privacy can be preserved. There are many resources available in telehealth for Washington State, and specifically the Washington State Telehealth Collaborative has many resources available on that website listed there. The NRTRC, the Northwest Regional Telehealth Resource Center, also has a telemental health toolkit. The Washington State Dental Association has webinars for teledentistry. The University of Washington Behavioral Health Institute also has resources, as well as the American Telemedicine Association, and many professional societies are also developing guidelines for their respective professions. A quick note on privacy. You are all familiar with HIPAA, enacted in 1996 to protect personal health information for patients. And HIPAA-compliant telemedicine technology is covered by a business associates agreement that provides these protections. And you may have heard also that the Department of Health and Human Services Office for Civil Rights has issued a notification of enforcement discretion for telehealth remote communications during the public health emergency. The OCR will exercise enforcement discretion, and so will not be imposing penalties for non-compliance with the regulatory requirements under HIPAA in connection with the good faith provision during the public health emergency. But we do recommend continuing to preserve patient privacy and using HIPAA technologies preferably as available. And please avoid using public-facing platforms in the provision of telehealth. And when using non-HIPAA compliant technology, providers should inform patients that non-HIPAA compliant technology is being used and still ensure patient privacy to the best of their ability, including only sharing or communicating PHI with individuals authorized to receive the information, enabling whatever security and privacy features are available on the telehealth technology being used. And also keep in mind that billing for HIPAA compliant and non-HIPAA compliant audio video technologies can be different, as we addressed in the telemedicine and telehealth overview. In additional support of our safety net providers, you may have heard about our Zoom license program, and just want to review that here as an additional resource. We have procured a limited number of Zoom licenses to facilitate continuity of care when it would otherwise be compromised due to disruption caused by the pandemic. Zoom, if you're not familiar with it, it is pretty easy to use video conferencing software. The licenses that we've procured are HIPAA and 42 CFR Part 2 compliant under a BAA obtained by the Healthcare Authority. Users need a device with a camera and internet connection and a microphone in order to use it. And we do have our application link listed here. Our distribution focuses on individual providers who are primary care, dental providers, therapy providers, licensed health, behavioral health professionals, and you'll see some examples down there. These licenses are reserved and prioritized for those who have active provider licenses and are currently seeing patients. Serve a meaningful number of Medicaid patients, don't already have access to HIPAA compliant video capabilities, are in smaller practices with less infrastructure, and serve children, adolescents, pregnant or parenting women, or tribal members. We do have a telehealth inbox available at the email address that you see there. That link to all of our COVID-19 information and the Department of Health testing survey at the link at the bottom there. So with that, Matt, I believe that we have some time now for Q&A, and we have our fantastic Healthcare Authority team as panelists available to answer questions that you guys may have.
All right. So we've been monitoring questions coming in. Thank you very much. We have many, and I will just say we will probably not have time to get to all of them, but we have been picking out ones that seem widely applicable. And again, we'll be following up after the presentation for ones that we cannot touch. So I will just jump right in. I think you may have touched on this, but it's regarding documentation requirements. People are receiving conflicting advice. Requirements can include organization, site, start and stop time, duration, identification of patient. It seems excessive. Can we just document time spent seems reasonable, consent and ID? Is there anything you can offer around that?
Sure. Gail or Jody, do you want to address that question?
This is Jody. I think that the guidance I would give you is, if you're doing telemedicine, we had pretty strict instructions in the physician's billing guide on the expectations of documentation. After that, what I would say is, as a provider, I would document what I think I needed to justify the code that I'm using to bill and to justify the services that I'm billing. So if you are able to not do some of that stuff, and you feel that if somebody was to ask you a question, you would be able to support that, then maybe that would make sense. I, however, personally would like to, if it was me and I was documenting, I would want to include as much information as possible, because this, again, is a new situation and a new modality that we are all learning from. And I'm going to guess it's going to be hard to remember those details later. And I would just want to put it all down on paper. Does that help?
I don't think we'll be able to monitor the live responses, but yeah, I think we could just move on to the next question. We have a nurse who triages phone calls from patients and can either resolve their question, refer them to a UC, or will have them speak to a doctor. Can we bill for her triage calls that do not end up going directly to a doctor?
I would think that would, this is Jody again, I would think that that would fall under, looking at what the CPT code is. And if it meets that requirement of a 99211 or not.
Or Jody, it could also be billed as the telephone consult, right? The lowest level, depending on how much time was spent.
Yes, I would think that would probably also work.
Yeah, so either one would be applicable.
Thank you. Is genetic counseling covered under telehealth?
Yes, this is Jody, and genetic counseling actually has been called out as having telemedicine, and telehealth is just extending that. And so yes, it would still be covered under that.
Okay. Here's one. I am trying to better understand HCA policy that appears to mean that there is payment parity for telephone visits when a patient is unable to use video technology for their visit. Can you please clarify this rule?
Well, we can confirm that understanding. This is Gail. That what the intent was to be able to reimburse for services at the same level we would for an inpatient or an in-person. So we have tried to establish a billing mechanism that allows you to bill a code that represents the service you rendered and make sure that you are paid equitable to the in-person visit. So your understanding is correct.
Okay. This one is situation specific, but I think we should address it. Our claims for EM services billed with the required modifiers are not being paid at parity for children's primary health care. Are other practices seeing this? When appealed, we were directed to the allowable spreadsheet. The spreadsheet does not match parity for children's primary health care.
So Jody, we need to know who they were billing.
Yeah, I agree. What I think what we need to know is more details. So if they were able to send in some details into the inbox, it would be more helpful.
Okay, and we can follow up.
Listed there. Yeah, so this is the HCA_COVID-19 at hca.wa.gov address. It's listed on the screen here.
And Matt, let me say this. This is Gail. We appreciate that you bring these things to our attention. Things don't always work out the way you design them on the first round. So we appreciate that you let us know so that we can work with the fee-for-service system or our managed care organizations and address those places where it's not, where the reimbursement policy is not being applied in your receipt of your payments.
Another question. CMS just published another update to services provided during the pandemic. This is from the press release. Is HCA planning to follow this policy change? Hospitals may bill as the originating site for telehealth services furnished by hospital-based practitioners to Medicare patients registered as hospital outpatients.
This is Jody. I think that we will have to look at that new information and evaluate how that would work in our system before I'd be able to answer that question. But we will do that, and if there's a change, we will publish it on the FAQ.
Can you provide any guidance? I think Sharissa was touching on this, but can you provide any guidance for antibody testing to determine immunity? I think we covered the answer, but I wanted to bring it up again.
Yeah, this is Chris. I think, do we still have Sharice on the line? I think she may have had to drop off. Yeah, so at this point, I think there's a lot of uncertainty just around, one, the accuracy of the tests, but also if someone's serologies are positive for antibodies, what that means in terms of reinfection, duration of immunity, et cetera. But that is something that we are closely keeping an eye on.
Okay, this may blend into that, but a question regarding the false negative rate of current testing, and in an asymptomatic person, should there be a duplicate test done if the first is negative? Are those allowed and paid for?
I don't think that we have a good understanding. Oh, who's that?
Oh, this is Jody. What I would say is if there's medical necessity to perform the test that we're covering per the doctor's evaluation, then it would be covered.
And I was just going to say, I don't think we have a comprehensive understanding of the false negative rate, but yes, yeah, would reiterate Jody's point there about coverage.
The next question may be a good item for follow-up, but someone on the phone might know. People have been inundated with an avalanche of calls from patients overwhelming our RNs and providers. Any clarifying communication from DOH and HCA would be greatly appreciated, specific to antibody testing.
Chris?
Great, we'll take that back.
Chris? I'm
Oh,
back
hey,
on. I'm sorry if that would be helpful for me to respond to that.
Sure.
So I think the information for antibody testing right now is to really focus on the simple piece of what it tells us. If the test is being done in a CLIA certified lab, we can be fairly assured that it's an accurate test in terms of identifying IgG most likely for exposure to SARS-CoV-2. So if it's in a lab, they probably have been exposed. What that exposure means, we don't know. We don't know if it means that they're immune. If we can't tell them that, then we can't provide any assurance related to the fact that they have an antibody. Hopefully over time, we'll be able to say yes, and you need a booster after we have a vaccine. But right now, that's all we can say. The point of care tests, there have been at least 100 marketed in the last couple weeks, none of which have gone through FDA approval. So if people are asking about antibody tests that they can get at home or in a drive-through situation, they are not likely FDA approved, and those results are not reliable.
Thank you. A question about home pregnancy tests. Does that Medicaid policy permit home pregnancy tests to be the sole determinant of pregnancy, or is there a requirement for a clinic visit?
This is Jody. I'm a little confused by the question. Is the question, would we pay for the home pregnancy test?
I think it's about, if I were to interpret this, it would be, is telehealth, can you do this via telehealth, via home pregnancy test, or do they need to come into the clinic and take that risk in order to have it paid for?
Oh.
It might be better to take it off. I'll leave it to you.
Yeah, I think I would have to look into that. Thank you.
Yeah. Matt, it sounds like someone's asking, would we pay for the over-the-counter pregnancy test? I don't believe that's covered, Jody. And then if a provider were to have a consult with someone based on a positive test that they were I guess, showing the provider through some kind of visual means that's available. That encounter, that visit, quote unquote, should be billed, and we would cover that just like we would any other visit. But I do not believe that we cover over-the-counter pregnancy tests. But the post-care we would cover just like we're talking about right here in this webinar. Right, Jody?
Yes, if the question is, would we pay for the actual tests that you buy at Safeway, the answer would be no. But yes, we would definitely cover the medical care involved.
Will there be an additional compensation for having to change out our PPE from normal PPE to N95 PPE for dental services?
Is Pixie on? She'll mute.
She's off.
Yep, I'm just trying to get unmuted. Can you repeat that question?
Sure thing. Yeah, sure thing. Will there be an additional compensation for having to change out their standard PPE from normal PPE to N95?
At this time, there is no additional reimbursement for that. But we will continue to look into it as things change.
Okay, we have time for a couple more. One person asks, we know that it says MCOs may have their own rules. We have called a few and just been informed that they would have to look at the HCA guidelines. Would it be safe to assume that we can just use HCA guidelines if these telehealth visits are declined?
If they are what, Matt?
If they are declined.
Declined. I'm not exactly sure what that word means in this context. But the managed care organizations have all agreed to follow the healthcare authority's policies. Many of them are following the FAQs and the instructions. So if they're referring you back to our FAQs, then indeed that is their billing procedure. I know that one plan, I believe it's Molina, isn't quite following all of the billing instruction aspect of the FAQs because their system requires the GT code. But that's if I recall correctly, that's the only one that is slightly off from what our FAQs state. If you're speaking to having claims that are denied that you have billed, then I would offer that if you submit the information to the email address that we have provided on this questions page that you're seeing there, the very first address, I would love to see the claim, client ID, and the claim number to which you are referring, and I will be happy to work with the managed care organization to address why your claim was denied.
Okay, thank you. I think we have time for most of the questions that we are getting to now have been addressed with other questions, or they are very code specific, and so I think they'd be best to be followed up afterwards, and then we can address them one-on-one. But there's a couple more. Does AmeriGroup allow doctors to use platforms other than Live Health Online for telemedicine? I've been told AmeriGroup only allows their platform for coverage.
So if you are, this is Gail again, so if you are referencing the telehealth program that they have implemented, yes, that is an option for providers and clients, but no, that is not the only option that they provide. So that need to control that understanding or control that rumor, because all of the plans are reimbursing providers. For those of you who are on the phone, who are providing services to clients and reimbursing you for that service, just like Dr. Chen has reviewed today. So they are to reimburse you for providing that telehealth, telemedicine service.
Thank you. The most frequently asked question I can actually take, and yes, we will, right after. But Dr. Chen, I believe we have cleared the questions that are appropriate for the webinar.
Great. Thanks so much for joining, everyone. Very much appreciate your participation. Again, we'll make these slides available after the webinar is complete, and you'll also be able to find all of the FAQs that we addressed on our website. We will be issuing a survey after the webinar is over. It will come to your email address. If you found this webinar helpful, please let us know. If there are other topics that you would like follow-on webinars about, also please let us know, and we'll be happy to review those responses. Thanks again, and yep, hope you have a good rest of the week.